thank you for your kind presentation, and thank you to Promadon for this opportunity to exchange about our experience in France. As Jan Paul said, we've been unfortunately we are without any possibility to use vaginal meshes now since 18 months. And I will start this presentation by some disclosure presentation. I am a consultant for some companies, and I have some patents in the field of urogynecology. I will talk to you about what happened this year in France, because it was the last year, of course, was without any vaginal mesh, but in the same time we had the COVID as anywhere else. So I will just tell you what happened during that year. I will talk to you about what we miss about the vaginal meshes at that time and what we try to keep coming from the last vaginal meshes we've been using in France. And then try to develop what we try to use now, the traditional autologous repairs with apical suspensions and the use of fascia and vagina for the treatment of prolapse. So this last year in France, of course, was dominated, as in many countries, by the COVID. And what happened was a decrease of the number of surgeries in France during that period. If we look at 9 months from March to last December, we had a reduction of nearly 40% of the surgeries in POP and incontinence, and that was much more in incontinence, nearly 50% of reduction of the surgeries for stress incontinence, and about 30% of reduction for the POP surgery. There were less patients operated with comorbidity as obesity, diabetes. And of course, what we saw was a decrease of the number of vaginal roots, a small increase of laparotomy and of laparoscopic sacrocolpopexy. Probably the lack of vaginal mesh will increase and will continue to increase a little the rate of laparoscopic sacrocolpopexy in France. Now, we were using vaginal meshes quite a lot, perhaps too much in France at least, but what we loved in the concept was the permanent support that was provided by the synthetic mesh. The second thing was that it helped us to standardize the surgical techniques, and now that we are back to autologous repairs, you know as well as me, the number of variations that we can see technically from one surgeon or one team to another one. And the meshes that we were using were both addressing apical support and apical suspension and the organ support. In the other hand, most of the time the organ support was done by the mesh itself, and the suspension, the apical suspension, was done by a suture for the sacrocolpopexy, for example, the support to the prevertebral ligament. The support was done to the apical suspension was done to the posterior sacrospinous suspension with the first meshes we were using, the TVM, the ProLift, and other meshes like that. And the last mesh we were using was suspended for the apical suspension by the anterior root to the sacrospinous ligament and addressing both anterior sacrospinous suspension and the vaginal support. And that's what we miss at that time the most, because we know that most of the clinical situation that we see have an association of cystocele and apical prolapse, and that's up to nearly 80% of the cystocele that we see that need both an apical repair and a support of the bladder at the same time. We know that isolated anterior repairs without any apical suspension are frequently not enough in terms of anatomy. And of course, we see in France an increase of laparoscopic sacrocolpopexy, as it is the gold standard in France and recommended by many societies at that time for the apical suspension. And we try to rediscover, and that's what I will share with you, this rediscovery of a vaginal autologous surgery. So this autologous surgery, I will talk about the apical suspension first and then go to the support using the fascia and the vagina. If we look at the apical suspension, we have, of course, some recommendations coming from the ICI, but coming from the OGS too. And most of them will tell you that the gold standard for the vault suspension is the laparoscopic sacrocolpopexy repair. And vaginally, they will recommend the sacrospinous suspension and the uterosacral colpopexy. Most of the time, we cannot do for any patient a laparoscopic sacrocolpopexy because that's the indication in France at that time. The first indication is to do an apical suspension by the sacropexy. And we know that in many situations, it's a limitation and sometimes a difficulty to go by the abdominal route. And we see some limitations. Of course, there are patients with contraindications for laparoscopy coming from comorbidities, a major obesity, previous pelvic surgeries, previous sacrocolpopexy too. We have now patients, I suppose, as well as in other countries that refuse any mesh and that do not want any foreign body to treat the prolapse. So they have to go back to a vaginal procedure. Some patients don't want a general anesthesia or cannot have a general anesthesia, and sometimes a concomitant perineal repair is needed. So vaginal route still has an interest, of course. And if we look here at the recommendations of OGS and IUGA, the joint publication that was published in 2020, we see that there are both abdominal suspensions or vaginal suspensions. And again, we go to the sacrospinous or the uterosacral or the iliococcygeus fixation. I will talk mainly about the vaginal apical treatment that we can use, that we use at that time in France. And we see the recommendations again for the different kind of anatomical structures that we can use for this apical suspension. And I will focus on the sacrospinous suspension and especially on the anterior apical suspensions to the sacrospinous ligaments. We know that the anterior approach for the sacrospinous suspension that was used for many anterior meshes is efficient as an apical suspension compared to the posterior suspension. There has been some publication telling us that they have a good TVL with the anterior sacrospinous suspension that is as efficient as the posterior sacrospinous suspension. We know that we can treat by only one incision the level 1 and 2 of the Lancy in the case of a cystocele if we use anterior sacrospinous suspension approach. The axis of this suspension is probably, as we can see on the drawing here, a little more medial because the suspension goes over the uterosacral ligaments rather than under them by the posterior route. And we hope, but it's not proved at that time, that there will be a little less secondary cystoceles induced by the anterior sacrospinous suspensions compared to the posterior sacrospinous route. Now you can do an anterior autologous repair by the same incision, a colpectomy, a plication, what I will show you, a paletot or a plastron using the fascia or the vagina to support the bladder. We keep the uterus most of the time with this approach, and that leaves the option for a future sacrocolpopexy if needed. The posterior sacrospinous suspension is well known to be efficient, of course, but is known to be able to produce some secondary cystocele, and there are some publications with up to 30% of reintervention for a secondary cystocele. And again, we hope that it will not happen with the anterior approach. This anterior approach has been published now many years ago, and it was used with sutures in the beginning and then with meshes with this anterior sacrospinous suspension. And you can see that they had good anatomical results with some failures around 10 to 12% of anatomical failures in the early post-operative course. The publication of Goldberg compared posterior sacrospinous suspension to anterior one with the same anatomical results and a good TVL at the postoperative course. And there are some publications since this period about anterior bilateral sacrospinous ligament suspensions, and showing us that it's a safe route for the apical repair and with good anatomical results, at least for the early postoperative course. At that time in France, when we look at the apical suspensions, I will choose the anterior sacrospinous suspension anytime there is an anterior defect associated with the apical defect. And I will keep now the posterior sacrospinous suspension only in case of predominant posterior vaginal defect without any significant cystocele for the patient. And for most of our patients, at least when there is no uterine pathology, we will preserve the uterus. It's quite easy at the beginning of the surgery to simulate the results of an apical suspension, and you can simulate the anterior suspension or the posterior suspension to the sacrospinous ligament and see what is left in terms of cystocele and in terms of anatomy, secondary. And if we look at the drawings here, we are looking, especially for the anterior sacrospinous suspension, at any kind of permanent cystocele, even with the apical suspension. If we see that there is cystocele remaining after the apical simulation suspension, then we will do an anterior repair at the same time at the anterior sacrospinous suspension. The anterior sacrospinous suspension is done vaginally, of course. I have a short video. I'll try to show it and to share it with you, and try perhaps to accelerate a little if it lasts a little too much. We do it in different steps with the exposition and the vaginal infiltration that we use to do for any vaginal surgery. And we expose the anterior vaginal wall. Then we will do the infiltration. And then after the infiltration, we go for the incision of the vagina. This vaginal incision is done medially. We open the vagina until we reach the infiltration zone. And then we will dissect on both sides between the fascia and the bladder to be able to open the paravesical spaces. We expose the vagina, keeping the fascia with the mucosa on both sides. And then we will go for the dissection on the sides. This vesicovaginal dissection is at risk because, of course, it can give you some risk of a bladder injury when you open the paravesical space. It happens from 1 to 2% of the patients. And with the finger inside the dissection, the paravesical dissection, we will reach the anatomical landmarks, especially the spine, the ischial spine, and then the sacrospinous ligament. You can use then any device to help you because the space is narrow. We use, especially in the beginning of our experience, the suture device, and we use the capio, for example, to place a suture inside the ligament. But of course, any other devices can be used to have a strong suspension to this sacrospinous ligament. So we put the suture in place, as I told you, under control of the finger, with a protection of the bladder when you use, of course, the material. The suture is placed about 2 centimeters away from the spine. And we check the solidity of the prehension of the ligament. Then we will suspend the vaginal apex or the cervix if the patient has the uterus in place. This is a monofilament proline suture. We do we place one on each side and suspend it to the uterus, cervix. And then if I go a little further, we will start to close the vagina and then put the tension on the sutures just before we end the closing, and then finish to close the vagina. The anatomical results is always good, at least in the early post-operative course. And I will show you some of the failures that we had in the post-operative course. For example, we see here what we checked 6 months after the beginning of our suspensions with sutures to the sacrospinous ligaments. And you see that we had some early failures at the 3 months follow-up for the patients. And we thought that it was much more than what we used to see using a vaginal mesh inside the ligament. So there is probably a kind of fragility to the suspension if you use only sutures rather than the arm of the mesh inside the ligament. And to try to reduce this risk, we decided first, in case of significant cystocele, to add a systematic treatment of the cystocele using application or a paletot, for example. And we decided to do always a double pass of the suture in the sacrospinous ligament on each side. Anchoring could be a solution too, to improve the suspension inside the ligament rather than the suture. And in case of a large stage 4 hysterocele, we use both anterior and posterior sacrospinous suspension at the same time. So the potential benefits of this anterior approach for the sacrospinous suspension will be first the efficiency of the apical suspension. Second, you will be able to treat the cystocele at the same time. The more medial axis of the suspension with a less risk of de novo cystocele in the postoperative course, and the possible concomitant anterior autologous repair, the uterine preservation. Now, if we look at the technique we will use without mesh to support the bladder, we will use the fascia most of the time, and that's quite classical. This is the plication of the fascia on this side here, but we use what we call the paletot in front often. So we dissect the fascia, the Alban fascia from the mucosa on both sides, and we double it in the midline. So as you can see here on this drawing, this is frequently associated to the anterior sacrospinous suspension, and we can do only a colpectomy, a bladder plication. Sometimes we use uterosacral ligament if we do a vaginal hysterectomy, what we call a Campbell, which is a crossing of the two uterosacral ligaments in the pubic bone to support the bladder, or we use what we call the paletot, as I showed you just before, and what is shown on this drawing here. We can do a paravaginal lateral suspension of the vagina, of course, using sutures or any device to help to place the sutures. And we will suspend the vaginal cul-de-sac on the side. And we've been publishing a few years ago what we called the plastron. It was published 20 years ago now. And this, as you can see here, this is a combination of a paravaginal suspension with a medial support. The medial support is done by the vagina that we dissect and that we keep on the bladder. And we will suspend the sides of this plastron on the arcus tendineus on both sides and suspend it to the sacrospinous ligament by the anterior root too at the same time. So it makes a little like a vaginal autologous mesh with a secondary risk of mucocele. That's why we recommend to do an abrasion or an excision of the vaginal mucosa before you bury this square of vagina under the bladder. So that was a technique we were doing before using any vaginal mesh, and that we tried to develop again. And you see on the side here what will happen after the placement of the sutures with the vaginal square, the vaginal mesh, let's say, under the bladder, suspended to the sacrospinous ligament on the apical, for the apical suspension, and to the arcus tendineus laterally to suspend the lateral part of the bladder. I have again a short video if I have time. Is it okay, Jan-Paul, for the video?
Very okay. We see very interesting things. Please go ahead.
Interesting, but not completely evaluated at that time, Jan-Paul. But we did it 20 years ago, and you see that we were, that's why we were so, it was so easy for us to use a vaginal mesh in the beginning, a synthetic mesh, because we were doing already a kind of vaginal mesh with the square of vagina that you will suspend to the sacrospinous ligament and the lateral part of the arcus tendineus. And you see that you mark the vaginal square, then you dissect both sides in the paravesical space. Doing that, you will access laterally, of course, to the spine, and then to the sacrospinous ligament and to the arcus tendineus of the pelvic fascia. It's, of course, much more invasive than a simple plication of the bladder fascia. So it's something that we do only in case of large cystocele, when the apical suspension is not enough to treat the cystocele. Then on the control of the finger, we will use again a capio to put in place inside the sacrospinous ligament, and then on the arcus tendineus of the pelvic fascia on the side, the sutures of proline that we will use for the suspension. This is here the second passage that we do on the same size inside the sacrospinous ligament. And let me go a little faster. You have the suture, this first one inside the sacrospinous ligament, and then we will put two other sutures on the side to the arcus tendineus. At the end of the procedure, you start closing. Before you close completely the vagina, you put in tension the sutures. This is the sacrospinous suspension here for the first suture. You don't try to suspend it in contact to the ligament, of course, because you want it to be in the midline at the end and not completely lateralized. And you will progressively put tension on all the sutures. At the end, before you close, you can see the square of vagina here that is placed under the bladder and suspended to the sacrospinous ligament and the arcus tendineus of the pelvic fascia. And then you finish to close the vagina before the end of the surgery. So that's an interesting way, let's say, to be able to address a large cystocele with an apical defect with only one vaginal incision, and being able to keep the uterus in place if the patient wants to keep her uterus, which is the case often in France. Okay, so this is the conclusion of this presentation. Of course, 1 year without mesh was not a pleasure, especially with the COVID coming more during this year. But at least it takes us back to interesting vaginal surgical techniques without any mesh. And as you see, we are working on the vaginal sacrospinous suspension by the anterior route, and some new, or let's say old, anterior vaginal wall repairs that we want to develop to be able to address all kinds of cystoceles. These surgical options, of course, can be offered in alternative to laparoscopic sacropexy in case of a choice of the patient or of the surgeon, but they need to be evaluated because they were evaluated 20 years ago with good anatomical results, but we don't have enough evaluation of the pain, the sexual activity, and all the possible and potential complications of these surgeries. Thank you very much.
Thank you, Michel. Excellent lecture. I learned a lot, and I think many people did as well. And it's also interesting to realize how extremely different our practices are within Europe. Are you aware of plastron being evaluated or performed in other European countries?
I think it's a very French procedure because it was described in my team 20 years ago. And as everyone shifted to the synthetic meshes just a few years after that, I think people stopped using it, except in France, and we used it from time to time. For example, for us, there are other teams using it in France, and there is a randomized study comparing traditional vaginal plication against the plastron in France at that time with different teams.
And what was the outcome?
It's in process.
Yeah,
that's the conclusion.
that's for the next expert meeting then.
Of course.
Martina, do you have some questions collected? Because I do not see any. I have a few myself.
No, there just came one compliment in to your presentation from Professor Hübner. So thank you for your presentation, but no questions so far.
Yeah. I have one, Michel, if you allow me. I see you perform a thick vaginal wall dissection at the moment that you go from the anterior vaginal wall to the sacrospinous ligaments. It's something we do not do. We keep the fascia on the other side, especially to prevent bladder lesions, and because we feel that we have a little bit more strength if we plicate. Why is that? Why do you do the thick wall dissection?
We think that if you keep the fascia, you know, it's only the deep part of the vagina, this fascia. Sometimes it's not so strong. And if you keep the fascia with the mucosa, probably it will be a little stronger than only the fascia. And we can do what you described if we do only application of the fascia, for example, because it's of course safer to keep the fascia on the bladder at that time, plicate the fascia in contact with the bladder. But we used, as you saw, often we try to put a double layer of fascia on the bladder, what we call the paletot. And this, you will need to dissect between the fascia and the bladder and between the fascia and the mucosa. So often we do directly a complete dissection between the fascia and the bladder. But I agree that there is a little more risk of a bladder injury if you do that.
Yeah. Another question I have is, we have recently more and more interest in level 3 support, meaning that we approximate the bulbocavernosus muscles. We do not go deep. And we feel that that also helps to reduce a little bit the risk on cystocele formation, maybe because we change the axis in the opposite way as the sacrospinous fixation does. Any new insights on that, or all experience-based?
That's only experience-based, but I agree that sometimes you need to do something posteriorly and very close to the vulva to change a little the axis and to reinforce the perineal body, of course.
Yeah. And another question I have is, in mesh surgery, in vaginal mesh surgery, I feel quite comfortable that the force transmission is divided about a larger surface. Whereas in these procedures that you have shown, the fixation points are less, so there is more force transmission on smaller surfaces. Do you feel that's a clinical relevant problem, or do you say no, it's not?
I think that's exactly what we saw in the beginning when I told you that we saw about 10 to 12% of early failures in the post-operative course using only sutures. I think it's due to the fact that the transmission of the force is completely different. And of course, the area of tension is much lower than the arm of the mesh coming all along the ligament. So that's why we try to improve the number of suspension. For example, adding some suspensions to the arcus tendinous of the pelvic fascia and trying to double the suture to have something a little more, to have something stronger for the suspension. But I think it's exactly, and I think it's normal. If you go back to no mesh surgery, you will have, of course, less complication due to the mesh. That's the benefit of the traditional autologous repairs, but you will have a little more failures anatomical failures in the other hand. So we try to improve it, but I'm sure there will still be a little more failures than if we were able to use vaginal meshes.
Yeah. Professor Naumann, any comments or insights?
No, my heart is beating because, Michel, you speak from my heart. In my lecture, I will break a big thumb for this technique to come from anterior for the sacrospinous fixation. For me, it's a real modern, innovative treatment. This is less invasive. It works fantastic. The axis of the vagina is very nice. You showed it nice in your video. I think this could be the future. The only thing, we in Germany, you know, we have a free entrance to meshes and tapes. And I have the chance to make this procedure with a small tape, this splinters tape. And if you have this small tape, you have more forces on the cervix and at the sacrospinous ligaments. And it's more stable, it's real more stable. We have done more than 400 cases without any recurrences. This is really amazing. But I'm completely lucky that you showed that is a real good way for the future.
Yeah, and I think it's always interesting to have alternatives anyway. If some patients doesn't want any mesh, it's important to know what we can use without any mesh that can be safe and give good anatomical results.
Yes. We still have a few more questions. Is there a similarity between the plastron and the bridge repair as described by Peter Petros?
It looks like a little, but I need to go a little deeper inside the technical description if I want to be able to answer. So I will not completely answer to that. I don't know enough. I didn't practice myself the technique described by Papa Petros.
Okay. And do you feel that colpectomy narrows the vagina, or is it not a clinical relevant problem?
I think that the colpectomy narrows the vagina, and the plastron, for example, is doing a colpectomy for sure, because the part of the vagina that you leave under the bladder is removed from the vagina at the end. So you need to be careful for that and not to remove too much. I think there is often an elongation of the vagina in case of a significant prolapse, so you can remove a part of the vagina, but you need to be very careful because you need not to remove too much.
Yeah. Okay. Danielle Ohm from the Netherlands asks whether with the plastron technique you have problems with wound healing. I think you mentioned mucocele.
Yeah.
But do you also have abscesses or?
Abscesses, no, not already, but of course it can probably happen. It's only there is only a Prolene suture inside the dissection, so the risk is not higher probably compared to a traditional repair. I think the risk using the plastron is to do a bladder injury because of the large dissection in contact with the bladder, as you said already, Jan Paul. And the risk of infection is very low. But the risk, when we had mucocele, it was especially for patients who had a hormonal treatment, which is not the case most of the time in that period. But we saw that 20 years ago. Nearly all the patients had hormonal therapy after menopausal, and then some of them happened to have a small mucocele under the bladder that looked like a recurrent cystocele. But when you did imaging for that, just a sonography, you saw that it was really a small pocket of mucus under the vagina. So that's not difficult to address, but it can be a necessity to go back to the OR to treat that. So that's why we try to remove the mucosa as much as you can.
There's one question from Argentina. It's in Spanish. I hope I translate as well. But the question is whether you consider the fascia of Alban for your cystocele repair.
Yeah, as I told you, the palto, when we cover, we do a covering of the fascia on the both sides. We use the Alban fascia and we dissect especially the Alban fascia, of course, and sometimes we do application of the Alban fascia as you described. So we like this fascia and we use it as much as we can.
Thank you again, Michel, for a very inspiring presentation. And I have noticed that your university has also focused education in this field, and that you organize workshops, webinar, and I think that we should try to attend to those meetings, either web-based or in the future live again, because the exchange of knowledge is very valuable.
Yeah, and see everyone in Lille will be a pleasure. So you're most welcome.